Good morning, everyone. Today is Tuesday, January 26, 2021. Nice and cold day, but sunshine is out there. I don't know. They're expecting rain or something like that. I would like to introduce everybody to Dr. Alex Foxman. He's an internal medicine and founder and medical director of Mobile Physician Associates, serving Southern California since 2009. And Dr. Foxman just told me that they had just surpassed 50,000 in-home visits.
That's correct.
Well, welcome to
Thank
our
you.
podcast. How are you?
I'm great. Thanks for having me. Always a pleasure.
Thank you. This is going to be an interesting topic. We don't really have a topic. We'll just talk about significant issues that are happening in the healthcare. We will discuss probably a little bit about COVID-19 and the injections and long-term care facilities and so on and so forth. And we'll see where it goes. What do you think about that?
Absolutely.
Yeah.
Let's do it.
So let's do it. Tell me. So what is your what do you see happening with COVID? You know, it started about a year ago, and where do you think it's going?
Yeah, COVID. What is COVID? No one talked. Everyone's talking about COVID. Look, it's a big problem. There are hardworking people trying to find solutions. We always talk about the bad things, but also sometimes we have to talk about the silver linings that occur with this infection as well. I mean, first, the bad things. We're well over 400,000 deaths in the United States. We have lots and lots of people that are still at high risk, including the senior community, chronic care people. We have hospitals, especially in Los Angeles, that are well over capacity. As an example, Cedars-Sinai, as we speak today, is over 130% of their ICU capacity. 40% of their patients are COVID.
How could it be over 130%?
Well, because they have to make more beds. So they're licensed for 100%, and then they have to make more beds, so they're above their capacity. And using the emergency waivers, they're able to make more beds. But that's not an infinite amount. So you could only have so many beds that they could have. So all of these are major issues. But the good news is what has been going on with COVID in regards to improvements in technology, improvements in care of patients, including immunizations. We rolled out one of the fastest immunizations in the history of mankind. We are currently immunizing people. We currently understand that this is going to give us an opportunity to try to get back to a new normalcy. And the new normal is something we could always, discuss further.
How effective are these vaccines? Do you find them? Because I heard on the news yesterday that now they're saying that there's some new strains of the COVID, and how will the vaccine be effective towards the new strain?
Yeah. So I think we have to understand that COVID-19, even though it's something that's important to us today, is something that's happened in humanity for millennia. As long as we've been humans, we've had a very big enemy. And that enemy is infectious disease, bacteria and viruses. These bacteria and viruses have been a severe enemy and have caused death to humans for thousands of years. And this will continue happening. What's different now is that we have technology to help reduce that significantly and to pivot when something like this comes about. The vaccine that's out right now is called an mRNA vaccine, a messenger RNA vaccine. And without getting into complex issues, this vaccine was very easily developed and very quickly developed in a time frame that was never possible before. It is 95% efficacious when you're giving 2 doses of these vaccines, both Pfizer and Moderna. And that's a pretty good benefit.
Is that going to be the same efficacy for the new strain, the one that came to
So
England?
the problem is just like with other viruses mutate. And that's common, not just for COVID, but for every single virus. As these viruses mutate, they're trying to find ways to inhabit our bodies and reproduce, and at the same time, hopefully keep us alive long enough so that they could reproduce enough and give it to other people. Viruses that kill humans too quickly actually die out. So there's a perfect combination. But as these viruses get mutated, they find better and more novel ways to infect us. Either they infect us more readily, or they keep us alive or sicker more readily, whatever it might be. I really believe that COVID-19 is going to be like an influenza in the future. It will be with us forever. It will be something that in the future we'll be getting not only flu shots every year, flu vaccines, but we'll also be getting COVID vaccines, or maybe a combination of both. And I think that unfortunately it's only a matter of time till the next COVID-22 or COVID-33 comes about, because this is something that we're going to be battling all the time. Many times we win the battle from viruses and bacteria, but it's going to be very difficult for us to win the war in the long run, unfortunately.
So do you see us going back to normal the way it was pre-COVID?
Well, I see us having a very, very slow time to normalcy. And the reason for that is, again, I think psychologically we've all been very, very heavily impacted as to what a viral pandemic could do to us. And I think that until we know that these mutations are really managed through immunizations, it's going to be tough to go back to the normalcy as we knew before, such as never wearing masks, such as occupying large spaces very close together. There's going to be a lot of psychological issues initially with this, but I think we'll get over it. And I think that by 2022, we should be back to our new normalcy.
What is new normalcy? Like wearing? Do you refer to as we will always wear masks when we're out and about? Will be able to go out and have events of 200, 300, 400 people? I mean, what's new normalcy?
New normalcy, I think, is really understanding who is at risk and who is not. When you don't get vaccinated, you not only risk yourself, but you risk other people as well. There is a lot of complexity to what's called herd immunity, when enough people are vaccinated that the virus can't expand anywhere else. And I think just like with influenza, we're going to have a problem with that. Remember that influenza every year, on average, in just the United States, kills between 20 and 80,000 people a year, every single year. Okay. Now, COVID has killed much more, and it's not going to be like that forever because now we have vaccines and so forth. But the reality is that there is, unfortunately, risk anytime you leave your house. But we take that risk because leaving the house is what life is all about, and we have to do it in a normal, understanding way.
So having a drink in a bar is fine.
Having a drink responsibly in a bar is fine. And as we know, look,
that's the doctor's talk.
Look, LA is opening up. Their restaurants, as an example, and hopefully the economy very soon, starting Friday, restaurants. Are we going to have more outbreaks? Yes, we are. But we have more therapeutics for this as well. As an example, we have ways that we could see that who's going to do poorly and who's going to do better. We have ways to protect the elderly and people who are sicker. We have monoclonal antibody therapies that have now been proven to significantly reduce the risk of severe illness, hospitalizations, ER visits. So we have all these different modalities that we have in place, just like we have antibiotics for pneumonia, right? If we didn't have antibiotics for pneumonia, the mortality rate would have been very, very high. But we have this, so we continue to evolve in medicine, in therapeutics to help us get to that point.
That being said, you do recommend getting the vaccine?
I do recommend getting the vaccine. The vaccine's been proven at this point very low risk, very low side effects.
To any age group?
To any age group. Okay. Yeah. The only right now risk is people who have severe infection, severe allergies to certain items. But that's very, very rare. Mm-hmm. And the side effects thus far have been very distant and far between.
Okay, because I one of my employees got the second shot yesterday, and she is so sick. It's I mean they told us actually when they gave us the injection, they told us, if you get sick, it's normal. It's your body just fighting the. Is this really? Did they infect you when they inject you with the vaccine? Do they inject a virus into you or
no?
I know you said it's mRNA, yeah. But
right. So it's a very novel concept. So messenger RNA, they inject a code, almost like a computer code, into your body. That computer code is picked up by your cells. Mm-hmm. The cells read this code because they think it's part of the body. And this code is for what's called the spike protein of the COVID-19. So you're not getting injected with the actual virus. Mm-hmm. You're getting injected with a message that your body reproduces and manufactures, like a factory, these spike proteins. These spike proteins circulate in the body, and your own immune system recognizes this as something foreign and makes antibodies, like a lock and key to this spike. And then your body remembers that next time I see the spike, I will know that I have antibodies for it and protect the body. So when you're exposed to actual COVID-19 before it could infect you, your body is able to prepare and deal with it.
So is this something that will need to happen? Okay, I get an injection, my body develops immunity for it, right? How long will it last? Do we need to do it annually? Is it once in a lifetime?
Great question. Nobody knows. Because it's only been 6 months since they developed this vaccine, they're not going to know how long it's going to last until that day comes. So far, we know it's going to be effective for at least 2 months In 3 months, we'll know if it's effective for 3 months. For 6 months, we'll know 6 months. So this is how it's going to go. It's the same thing with patients who were infected with COVID-19 and now have antibodies. We think you might have protection for over 3 months, and we know that's very factual for most patients. But is it going to be an immunity for 6 months? Is it going to be an immunity for a year, 5 years? We just don't know until that happens.
So we just have to wait through it and see if you can get reinfected after you get the vaccine.
Yeah, so for my practice, for example, from time to time, we check antibodies for our patients. Because if you have antibodies for COVID-19 with the current mutations, you know you have protection. But those same antibodies may not protect you if the mutations get too out of whack. It's the same thing, for example, the flu shot that you received last year or in 2019 is not going to protect you for this year's flu viruses. You have to get a new flu vaccine because the flu has multiple strains, multiple mutations, and every year you have to get immunized or you can get the flu.
So you get immunized for the flu every year because the flu virus changes or because the immunity in your body dies or diminishes?
The flu virus changes to the point where your body no longer recognizes the flu virus.
So that means if we had the same exact flu every year, we would not need vaccination
Correct.
every year?
I'll give you an example. Hepatitis.
Yeah.
Hepatitis rarely changes. If you get a hepatitis A or B vaccination, that's good for at least 25 to 30 years.
Oh, wow.
It's a long time, right? Because the hepatitis virus does not change that enough, even in normal evolution of the virus, to need another vaccine.
That's very interesting. Why don't we talk a little bit about your practice, because I know you visit a lot of long-term care facilities, right?
Absolutely.
And in the beginning of this pandemic, there were some severe outbreaks I heard in nursing homes and even in large-scale assisted living. How did you guys deal with it? Did you guys go in? Was it what was your protocol to handle? How did you handle residents or patients who got sick or didn't get sick or things and such?
So as you know, we have a mobile medical practice. We have physician extenders who go out traditionally to patient home and assisted living with our goal really of reducing hospitalization, ER utilization, having people managed in their home. Because it's tough, as you know, for some elderly and chronically ill people to go elsewhere. When COVID-19 first started, everyone panicked, including myself. We knew nothing about this virus, and I really thought that this was the virus that was going to take out 30% of the world's population. It was that scary. And once everything got locked down, there's a lot of panic. There's a lot of paranoia. And many times we weren't even allowed to go and see patients because there's such a concern of epidemics within facilities, which were happening all over the place. Many of these epidemics were happening because the caregivers were coming in. The caregivers had to go home sooner or later. They had to be with their families. Their families were everywhere. And they caused this combination of infection that they obviously brought back to the facility. So we were locked out of a lot of facilities, but we also wanted to keep our patients safe. So we pivoted very quickly. We brought in a huge amount of technology. The first thing was information technology in the form of telehealth. So we were able to provide telehealth services not just with these really fancy and difficult to use telehealth platforms, but we're able to do it either through Skype, through FaceTime, through products called Doximity, through all these different types of products.
How do you take a temperature? Somebody who's 20 miles from you over Skype. How do you take their temperature? How do you touch his or listen to his hard lungs?
Yeah. So that was just one of the technologies. The other thing that we embraced was mobile technology. So some of the things we deployed very rapidly was what's called remote patient monitoring. Remote patient monitoring is basically devices, just like a blood pressure cuff, pulse oximeter, a blood sugar monitor, scale, etc., that you deploy to the patient's home. Okay, you mail it to them.
Okay.
They're able to use these devices, and as soon as they use it through cell signal, without them needing to do anything else, it sends that information in real time to our office. In real time. So we're able to see the patient's blood pressure, their pulse, their temperature, their weight. All these different things are possible in real time. And we have algorithms that let us know when we need to contact someone or not. Because imagine if we have several thousand patients and we have 50,000 of these things come in. You can't look at everything.
You have to filter through them somehow.
So artificial intelligence and machine learning has helped us filter through all of this. We have chronic care managers that call these patients and they make sure they're taking their medications and so forth. That's a very important thing also. But also we've deployed very safe nurses, especially LVNs, that are able to implement our physicians' orders in the field. So as an example, if I see a patient via telehealth, I'm able to provide orders. I need to do blood work. I need to do an EKG. I need to do an electrocardiogram, an echocardiogram, whatever, you name it, we could do. And we deployed the staff, either nurses or ultrasound techs, to go and actually provide those services in the facility or in the home.
Okay.
These particular technologists or nurses are tested for COVID every day that they go out through rapid tests.
Yep.
So we try to make the experience as safe as possible. Nothing's ever 100%, but I think we're leaders in reducing infection, and we've had no cases of us infecting any of our patients so far.
Any horror? Thank God. Any horror stories you want to share with us?
Look,
or any recommendations based on the, it's been a year now, right? What have you learned, or what would you like to educate the public in terms of what's the truth and what's not the truth? And, because a lot of people are still having some doubts about getting the vaccine because they're saying they're chipping you and they'll follow you and all this stuff.
Yeah.
So how much of it over the past 12 months have you learned that you can share with us? You can tell us the good, the bad, and the ugly.
Absolutely. So the problem that we have today is we have a lot of information, but we have even more misinformation. There's a huge amount of things that I've seen and learned that people believe that are completely false. Okay. Such as a very good example: people who are asymptomatic could spread COVID. That's a huge one, and that's a big, kind of.
So is it true or false?
It is false.
So if I'm asymptomatic, I cannot spread it?
Right. So let me explain.
Oh, wow.
Symptoms, right, are kind of sometimes in the eye of the beholder. A symptom is something that is unusual that you feel, right, that may be defined as something that causes an illness or a process. Okay. As an example, if I wake up in the morning and I feel a little unwell or I have a runny nose, that's actually a symptom. If I feel foggy-headed, that's a symptom. If I have a fever, that's a symptom. A cough is a symptom, so forth and so on. But many people have mild symptoms. Cedars-Sinai, since March of 2020, has been doing an ongoing study where every single patient who comes to their facility for any sort of procedure must have a COVID negative PCR test, which is the most sensitive test, 99% sensitive and specific, within 72 hours of that procedure. They've done over 30,000 of these tests. And what they found, and it's very, very concrete and factual, is that the rate of asymptomatic patients who are COVID-19 positive by PCR is under 0.27%.
Wow.
Okay? That's fact. So and this is the way we run the practices. This is the way I manage my patients, and I'm yet to be wrong on this. Okay? Mm-hmm. When a patient is in an incubation period with almost any virus,
what's the incubation for COVID?
So within 5 days of being infected, where you still don't know, within 5 days, 90% of patients will get symptoms. Okay. What are the usual symptoms? Dry cough, fever, chills, loss of smell or taste, fatigue. Those are common, but there's a lot of uncommon things as well. We have plenty of patients who have a runny nose. We have plenty of patients who just have fever. We have plenty of patients who just feel foggy-headed and unwell. We have patients with gastrointestinal symptoms. You name it, okay? But those are the major things. By day 6 or 7, approximately 95% of patients who are infected will have symptoms. And by day 8 to 10, almost 99% of patients will have symptoms. Mm-hmm. So what I usually tell patients who call me panicked, yesterday I was in a room with someone who had COVID. Okay. All right. Well, let's start the clock. Okay. By 5 days, you have 90% to have symptoms. If you don't have it, you only have 10% of a chance that you actually have COVID.
Yeah.
Right. And that's the way the clock starts ticking.
Talking strictly statistics here.
Yeah.
Yeah. It's pretty. So what's the ugly?
What's the ugly? That there's a huge amount of people that are still dying. They are usually above the age of 60. Definitely above the age of 80, people that are in assisted living facilities and so forth. There is definitely an increased risk of death with people with comorbid conditions, obesity, diabetes, high blood pressure, COPD, all those things. These are the people that are dying. And unfortunately, the death rate, the mortality rate at Cedars-Sinai currently in the ICU is almost 45% for people who have COVID.
This is scary.
So it's very high, no matter what they do. But when you catch things early, when you have earlier therapeutics for these people.
Is there therapeutics?
Absolutely. So we are currently using, and we have mobile monoclonal antibody treatments. So these same treatments that you could only get in the hospital, we could now deploy to a patient's home or assisted living.
And what is it? Is it like an IV, some sort of?
It is an intravenous infusion, an IV, of antibodies, of COVID antibodies, synthetically manufactured and sometimes not, from people's plasma, that we infuse over an hour. The benefit is in the first 10 days of infection, and the benefit is better the earlier you get it. And even in mild cases with patients who have indications, it significantly reduces the risk of hospitalization or death significantly. So it's a really big step. And now you could get it in your home.
Wow, this is incredible. And is this covered by insurance?
So insurance covers some parts. And insurance, we mean the federal government. They will cover the cost of the actual monoclonal antibody, which is several $1,000s. And the infusion, the IV, is usually between $300 and $500.
And you need just one?
You just need one.
So you're referring to Medicare?
I'm referring to the federal government. The federal government has bought several $100 million of monoclonal antibodies, and they are providing it at no cost
got it.
to patients that meet the indications. What are the indications? Being either over the age of 75 or below the age of 75 with comorbid conditions and so forth.
Oh, I see.
Yeah.
Wow, this is very educational. I'm actually, a lot of stuff I thought otherwise, but apparently, research has its own factual data, so that's great.
But one thing that I think everyone needs to know is, number one is don't panic, stay calm. Okay, people are panicking all over the place. And the easiest way not to catch any infectious disease is simple. I spend a huge amount of time with patients in small closed rooms. I've been exposed to COVID multiple times. I've been exposed to influenza multiple times, and who knows what else. The reality is that I have never been infected, maybe sometimes through luck, but the reality is to reduce your risk, simple things. Wash your hands, don't touch your eyes, nose, and mouth, and follow the basic CDC guidelines at this point is the easiest thing for you to do. If you have access to an N95 or KN95 mask, such as, if I could find here, like this is what really protects you from inhaling viruses.
So those regular masks, I don't have one with me. Those, the blue ones, they're kind of what? Would you say they're useless?
I wouldn't say useless, but what they protect me from is you. If you have an infection and you're talking to me, it protects me from the respiratory particles, the sputum that is going through the air as we speak.
Okay.
But when you breathe in, you're
it doesn't filter
everything. It does not filter
it. So it protects who you are, not yourself.
That's what people think when surgeons wear this in the operating room. They think it's protecting the patient some way. It only is from the sputum. That's all it means. When the surgeon's looking over the patient, that's all it's protecting about. But it doesn't protect them from the viruses, from the bacteria, or anything like that. That's false.
That's very interesting.
Yeah.
Dr. Foxman, well, now you have this really. I don't know. Is this your kindergarten bag or what is? Can you share with us? I see you. So we work with Dr. Foxman for many years, and he always comes with this bag. I actually never asked him what it's about, but why don't you share with us? What do you have in there?
I like to be tech savvy, okay, but I also like a little bit of the old school. So this is an old school doctor's bag. Okay, it's who knows, probably 1920s.
Is it for real?
Yeah, it's real.
Where'd you get it?
It's real. A patient very early on in my career gave it to me, and as you can see, I've not taken very good care of it. It is very beat up because this is what I use when I go on visits. But what's inside is what really the technology is. So if you're interested, I'll show you.
Yeah, why not? Show us.
So laptop.
This is also from the 1920s?
It is not. No, this is not. But a laptop, which is cloud-based, has all of the patient's medical information in it. We do our orders in real time. We could get into other computer systems for lab work and so forth in here. So this is very, very valuable, and this is what we document on in real time.
So this is not only you, this is your entire team has the same setup, right?
Everyone has it. Everyone shares information.
Okay, good.
Okay. Temporal thermometer.
Yep.
Right? Very simple.
Yep.
Take their temperature.
Yep.
Right? Pulse oximeter.
Yep.
Very simple.
Yep.
Blood pressure cuff. Okay?
Yep.
Simple stuff.
Yep. Now, all of that stuff communicates with your computer?
This does not, but it's very easy to put in.
Yeah.
I mean, it's easy stuff, okay? Otoscope, ophthalmoscope. Look in people's eyes and ears.
Oh,
okay?
Interesting.
Very important stuff, okay? What else do we got in here? Hand sanitizer.
Hand sanitizer.
Very, always important. Wash your hands.
But for some reason, yours is empty.
Well, almost empty. I'll have to refill it. And then some other things. So, portable COVID tests. Okay? So, this is a rapid COVID test. We not only keep this in the field, But we also deploy it to our patient's home and assisted living, so it's ready there if a patient is sick. There's no reason to test a patient and get results in 3, 4, 5 days. You're missing a lot of time. Real-time testing is where things happen. So for example, in your facility, okay, we have COVID tests available that if someone has any sort of symptoms of any kind, with your nurse and through telehealth, we're in real time able to test them for illnesses, not just COVID, but for strep and for flu and everything. So we have these rapid tests that we not only deploy to facilities, but carry and give to our licensed vocational nurse to do in real time. Because time in infection is of the essence. If you wait too long, you miss the window. If you catch it appropriately, you not only miss the window to manage that patient, but you stop infection from occurring.
So wait a minute. Let's say you tested somebody real time right away and they come back positive. What do you do? To avoid the progression of the disease and to avoid avoiding infection, I get it. Isolate this. But what do you do for actual patient who's came positive?
So there's some very mild things that everyone could do very simply, because 99.5% of regular average people will have no bad outcome. It'll be like the flu or the cold.
Okay.
But there's that 0.5% which could be devastating. Okay. Even more sometimes, depending on the age population. The older, the worse, and more chronic conditions.
So don't get old.
Try not to get old. But vitamin C, vitamin D, and zinc, in that combination, especially vitamin D, has been shown to help the immune system fight off not only COVID, but many infections. I'm a big believer in vitamin D. I check levels of vitamin D for my patients and myself. I use the same things in my family as I do, so that's the first thing. But the other thing, which is really a game changer, is monoclonal antibody therapy as soon as possible, especially for the elder population. Every single patient that is COVID-19 positive, that is definitely over the age of 75, I recommend they get monoclonal antibodies. They are low risk, low side effect profile, and have been very effective, proven already, to really reduce hospitalizations and deaths from COVID-19.
Wow. So it's that readily available to anyone?
Amazingly, it is that readily available if you have the proper providers that know how to prescribe it and will prescribe it for you.
Amazing. Well, listen, it definitely for me was very educational and very informative. Hopefully our audience will feel the same way. I do want to thank you very much for joining us on today's podcast. Is there anything else you would like to share with us and the audience?
I know we're limited in time. I would love to come back again and share more. I mean, there's so much to talk about, and you're great. One thing that I want to say, and obviously this is not a platform for a sales pitch, but I've been involved with your organization for a very long time. And what
let's put some time frame. How long is very long time?
Since I started my mobile practice in 2009.
Wow.
Okay, so it's been a while.
Yeah.
I've seen your organization grow. I've seen all of the amazing steps that you've taken, all of the new facilities that are opening. The new one, for example, I think in San Clemente,
Correct.
Which is amazing, that's opening up. But what I really want to applaud you and your staff, everyone in your staff, not just you, but your executive staff, your nurses, even the people down to the cleaning crew. They've always had the highest level of care for your residents, and also you've always had the highest quality of care for everything you do, from your podcast, from your facilities, and so forth. So I want to applaud you for that.
Thank you.
Because that's an amazing thing that I rarely see, and I think that it's amazing how much heart and energy you put into everything you do.
Thank you.
So
thank you very much.
You're welcome.
Thank you, Dr. Foxman. This one again, Dr. Foxman with Mobile Physician Associate, and we will see him soon. Probably our next podcast with you. We'll host it probably sometimes in the summer at the new facility in San Clemente.
I look forward.
Thank you very much.